So hello dear students, today's topic is a pharmacological characteristic of antiplatelet drugs. Antiplatelet drugs. This is drugs which interfere with platelet function and are useful in the prophylaxis of thromboembolic disorders. And firstly, we should say about classification. We have four groups. This is COX inhibitors, this is P2Y12 receptor blockers, or shortly ADP receptor blockers, then glycoprotein 2B3A inhibitors, and then phosphodiesterase inhibitors. So COX inhibitors, we know only one drug is aspirin. Then ADP receptor blockers can be irreversible and reversible. Irreversible, these are ticlopidine, clopidogrel, prasugrel. Reversible, it's ticagrelor, cangrelor. Glycoprotein 2B3A inhibitors, the same, have two groups: monoclonal antibody and synthetic molecules. So drugs apixaban and eptifibadid tirofiban. Phosphodiesterase inhibitors, it will be dipyridamole and cilostazol. So on picture you see mechanism of action of all the groups of antiplatelet drugs. So firstly, it's aspirin thromboxane inhibitors. Its mechanism include inhibition of cyclooxygenase 1 enzyme, and it will be inhibition of thromboxane A2. Thromboxane A2 normally take a role in platelet activation. So if it's inhibition of thromboxane A2, platelet activation will be blocked. Next group, it is glycoprotein 2B3A receptor antagonists. So they inhibit this receptor. This receptor, they are on the surface of the platelet, and due to these receptors, they stick with fibrinogen, and it will be aggregation of platelets. So inhibition of these receptors leads to inhibition of aggregation. Next, it's PDA inhibitors. From the name of the group, we see that this group of drugs inhibit phosphodiesterase enzyme. This enzyme normally destroy CMP. So if CMP will not be destroyed because of phosphodiesterase inhibition, AMP increased, and like a result, it will be again decreasing of platelet activation. And next group, it is ADP receptor antagonists or blockers. So they block ADP receptor, and like a result, it will be again increasing of CMP, increasing of AMP, and decreasing of platelet activation. So now about the let's speak about the main drugs, group of drugs, and a special example of drugs. So aspirin acetylates and inhibits the enzyme COX-1 and thromboxane synthase, inactivating them irreversibly. Thromboxane A2 formation is suppressed at very low doses until fresh platelets are formed. So maximal inhibition of platelet function occurs at 75-150 mg aspirin per day. So please remember this dose: 75-150 mg in a day. Inhibition of COX-1 by aspirin in vessel wall decreases prostaglandins I2 synthesis as well. However, since intimal cells can synthesize fresh enzyme, activity returns rapidly. It's possible that a low doses, this 75-150 mg per day or 300 mg twice weekly, thromboxane A2 formation by platelets selectively suppressed, whereas in high dose, more than 900 mg a day, may decrease both thromboxane A2 and prostaglandin I2 production. Aspirin inhibits the release of ADP from platelets and they stick into each other, but has no effect on platelet survival time and their adhesion to damaged vessel wall. So next, ADP receptor blocker, phosphodiesterase inhibitor, it's dipyridamole. So it's vasodilator that was introduced for angina pectoris. It inhibits phosphodiesterase as well as blocks uptake of adenosine to increase platelet CMP, which in turn potentiates prostaglandin I2 and interferes with aggregation. Dipyridamole alone has little clinically significant effect but improves the response to warfarin, along with which it's used to decrease the incidence of thromboembolism in patients with prosthetic heart valves. Dipyridamole has also been used to enhance the antiplatelet action of aspirin. This combination may additionally lower the risk of stroke in patients with transient ischemic attack, but trials have failed to demonstrate additional benefit in prophylaxis of myocardial infarction. So dipyridamole we don't use in myocardial infarction, but with combination with aspirin we can use for TIA. Okay, next. Teclopidine, it's example of drug of ADP receptor blocker. So from the name of group is inhibit ADP receptor, like result said that it will be increasing of AMP, and if increasing of AMP it will be decreasing of binding to platelets of glycoprotein 2B3A receptor. Teclopidine is well absorbed orally, converted in liver to inactive metabolite, and it's eliminated with a plasma half-life time of 8 hours. However, because it causes irreversible blockade of ADP receptor, the effect on platelets accumulates. Peak platelet inhibition is produced after 8-10 days therapy, and the effect lasts 5-6 days after discounting the drug. Teclopidine has produced beneficial effects in stroke prevention, transitory ischemic attack, intermittent claudication, unstable angina, coronary artery bypass, graft, and secondary prophylaxis of myocardium infarction. But very often teclopidine, the same, should be used with aspirin. Next, abciximab, it's inhibitor of glycoproteins 2B3A receptor. So abciximab inhibits this receptor. The main risk is like side effect is hemorrhage, incidence of which can be reduced by carefully managing the concomitant heparin therapy. Thrombocytopenia is another complication. Abciximab shouldn't be used second time since risk of thrombocytopenia increases. Next side effects: constipation, ileus, and arrhythmias can be. And nowadays abciximab is a very expensive drug, but it's being used in unstable angina and as adjuvant to coronary thrombolysis. So, uses indication of all antiplatelet drugs. So mainly we should understand for what we use the aim. Aim of using antiplatelet drug is to prevent intravascular thrombosis and embolization with minimal risk of hemorrhage. The intensity of antiplatelet therapy is selected according to the thrombotic influences present in a patient. So mainly we should prevent thrombosis. So what diseases in what diseases we should use to prevent thrombosis? Firstly, it is coronary artery disease. So again, this dose that you should know, it's recommended the dose 75-150 50 mg per day should be given in post-myocardial patients. Primary prevention of ischemia with aspirin is of no proven benefit. So next drug that can be used for coronary artery disease, it's clopidogrel. It's an alternative to aspirin in symptomatic patients of ischemia. Continued aspirin clopidogrel prophylaxis in post-myocardial myocardium infarction patients clearly prevents reinfarction and reduces mortality. Next disease, it's acute coronary syndrome. So what does it mean? It's this drug can be used in unstable angina, in non-ST elevation myocardial infarction, and in ST elevation myocardial infarction. So in unstable angina we can use aspirin, clopidogrel. In non-ST elevation myocardial infarction, the same, aspirin plus clopidogrel. And in ST elevation myocardial infarction, different combinations like prasugrel plus aspirin. So the GP2B3A antagonist plus aspirin, and or clopidogrel. Next set, it's cerebrovascular disease. It means that in case of stroke, aspirin can be used. Once more, it can be in transitory ischemic attack. Can be aspirin or clopidogrel. And sometimes dipyridamole, but dipyridamole should be used only with a low dose aspirin. Next, prosthetic heart valves and arteriovenous shunts. So antiplatelet drugs used with warfarin reduce formation of microthrombi on artificial heart valves and the incidence of embolism. Aspirin is clearly effective but increases risk of bleeding due to warfarin. Dipyridamole doesn't increase bleeding risk, but incidence of thromboembolism is reduced when it's combined with an oral anticoagulant. Antiplatelet drugs also prolong the patency of chronic arteriovenous shunts implanted for hemodialysis and of vascular grafts. Next, it's venous thromboembolism, and next, peripheral vascular disease. The same, aspirin with combination in combination with clopidogrel can be used, like prevention of thromboembolism. On this table you see general characteristic of the drugs, so mechanism of action, side effects. So here I want to say about side effects. You see that each drug can lead to bleeding. Aspirin, except bleeding, can lead to gastrointestinal toxicity. It will be from its mechanism of action of blocking of prostaglandin E2, nausea, vomiting, gastric ulceration. That's why when patients take aspirin, we should control gastrointestinal problems. So clopidogrel has side effects like bleeding, rash, neutropenia, thrombotic thrombocytopenic purpura, and other drugs, mainly bleeding.